Hi, this is Andrea Kane, and I'm here with you for HIT 120 Pharmacology. We are moving on to week 3, drug mechanisms. If you wanted to crack open your basic concepts in pharmacology textbook, we are actually going to be starting on page 1 in chapter 1. Where to start? That's the name of chapter 1. And really quick, before we get too far into this, if you look at your syllabus, you can see that there are unit objectives 9.1.4, 9.2.4, 9.3.1, 9.3.2, and 9.4.1, and 9.4.2. Those are the things we're going to cover. We're going to talk about receptor theory, absorption, distribution, and clearance, pharmacokinetics, drug metabolism, and renal elimination. Want to reassure you, when you started looking through your textbook, you may have thought, oh my word, this is way, way over my head. We are going to look at this on a very simplistic level throughout all of this. Our textbook gives us more information than what we're going to use. For example, well, really quick, starting here. One of the first things that she writes is, you cannot learn everything about every drug available. And is that not comforting? You are not going to learn everything about every drug available in this course. That is not what this course is about. This is a course about what you need to know for pharmacology, for HIT, that will benefit you. On the bottom of page 1, she has a trivia sorter. And her view is that the best way to learn drugs is by learning their class, to organize the material in a way that minimizes the amount of information you have to memorize by grouping drugs, making associations really based on the drug class. So we are going to learn about the drug classes, absolutely, but what we're going to be focusing on are what are those most well-known, frequently used drugs under each class of drugs, and then what are their most common properties or effects. We will touch on a little bit of their mechanism of action, how do they work. We will touch a little bit on any fatal, rare, or common side effects and drug interactions. But for the most part, what I want you to come away with is well-known, frequently used drugs, their common properties or effects. And so that's why it's in blue here on the screen. And I put in a lot of slides with images so that we can look at those images and understand how things work, because I think that will really help us as we go through. I will describe those for as much as possible. Hopefully that will be helpful. If I could not find an attribution for the image, just know that I pulled it up on the internet. But if there was a way I could attribute it back to wherever its source was, I did. Most of the information in this slide presentation comes out of your book, but there are a few pieces of information at the end that we can touch base on. All right, so first thing we're going to learn about in your book, if you turn to page 5, is receptor theory. So let's talk about receptors. Receptors are like this doorknob over here. That's a receptor. It's on the outside of a cell. So think of the door as the cell. This doorknob is a receptor. And in order to open the door, you need some type of key, so to speak. Typical keys that fit perfectly are like hormones or neurotransmitters. That's a natural physical occurrence in the chemical occurrence in the body that is designed to fit that lock, turn the doorknob, and open the door. Okay? So hormones or neurotransmitters, they are the real key to the door. Agonists are drugs, and they work sort of like a pick. I live in a Victorian house. It was built in 1894, and most of the doors use skeleton keys. And my daughter who's 10, has become an expert at if the door is locked and she thinks she needs to get in, she finds a way to get in using another skeleton key into that door. She is like an agonist, a medication agonist. She is not the original key, but she's using another that can act as the key and can open the door. That is an agonist. Okay? An antagonist is like using a branch from a tree outside. You stick it in the door. Is it going to open it? Nope, it's not going to open it, but it's going to block that doorknob from being used by either a hormone or neurotransmitter key or by the agonist pick. Okay, so when we're talking receptor theory, you're going to be talking basically about agonists and antagonists until we get to the point where we talk about hormones or neurotransmitters. Hormones or neurotransmitters, they always fit in that receptor. That's what they were made for. It's a perfect fit. They'll open the door every time. An agonist is like that pick. It's a medication that is going to open the door. It just does it differently than the key because it's not the perfect fit, but it's a good enough fit that it'll unlock the door. An antagonist is that tree branch. It fits in the door and into, but it will never open it. All it does is block it so that you can't use an agonist and you can't use a hormone or a neurotransmitter. Hopefully this helps. All right, so let's talk about receptors. It says here in your book, a drug receptor is a specialized target macromolecule that binds a drug and mediates its pharmacological action. These receptors may be, okay, so now we're talking about receptors. These receptors may be enzymes, nucleic acids, or specialized membrane-bound proteins. It's the formation of the drug receptor complex that leads to a biological response. So let's start here with ketamine. Ketamine is looking for a ligand-gated ion channel receptor. And thankfully, we're never going to get into that kind of detail. But here you have an example of a receptor that ketamine is made to bind to. Insulin is looking for an enzyme-linked receptor. So when you put insulin in the body, that's what it needs, is to find that enzyme-linked receptor for it to work together in. Calcium antagonists, they try and block these voltage-gated ion channels. Because remember, antagonists, they're that tree branch. They're going to block it. Antiviral drugs are looking for DNA receptors. Glucocorticoids, they're looking for nuclear receptors to bind to. NSAIDs, non-steroidal anti-inflammatory drugs, or ACE inhibitors, they're both looking for enzymes as their receptors. Beta blockers and adrenaline look for GPCRs as their receptors. And all of these receptors, when they're bound, if they're bound by an agonist, it's going to initiate some kind of reaction. If they are bound by an antagonist, it's going to block anything from happening, and it may reverse it. So hopefully this visual helps. The drug targets are in the center, and these items have to attach to the receptor in order to influence the drug target. So we're back to our words, and this is on page 5, and it's right off of page 5. So an agonist is a compound that binds to a receptor and produces the biological response. Okay, I'll say that again. An agonist is a compound, so it's a medicine, a drug, what have you, that binds to a specific type of receptor and produces the biological response. And that's where you get the medication acting. A drug receptor, And that's where you're talking here. The agonist is going to get to a drug receptor. That is a specialized target macromolecule that binds a drug and then mediates its pharmacological action. It's the doorknob that opens so that the drug can go further and reach its target. So the agonist is that key pick. It's going to bind to a receptor, which is the doorknob, and the biological response is to open the door and do something beyond the door. Now, these receptors, these drug receptors, can be enzymes, nucleic acids, or specialized membrane-bound proteins. They can be any of those. When the drug and the receptor form this complex, when the pick of the agonist meets the doorknob of the receptor, it's going to have a biological response, which is to open the door, and then what happens after that. The magnitude of the response is proportional to the number of drug receptor complexes or the rate of drug receptor complexes. So, and that makes sense. If you have a building and it has 50 doors in it, and 45 of those 50 doors are picked and opened, you're going to get more access than you would if only 5 of those doors get picked and opened, right? So how does an agonist work? We kind of talked about this, but this gives you another idea. So you have a cell, and that's this dark gray circle. And you have this little area in here that is the receptor, this dark gray area that goes toward the inside. Natural agonists are like the gray key. They are made for that door. Those are substances within the body that have evolved to produce a response when they bind to and switch on a receptor. Those are those neurotransmitters we talked about, or hormones. Agonist drugs then mimic those natural agonists within the body, binding to the receptors to create the same effect, but more often with a much more significant physiological response. And we'll talk through this, but part of it is that the drugs have to be stronger than the natural agonists in the body. The agonist drugs have to be stronger because they're not the same. And they will go through and be metabolized by the liver, and a certain portion of them will be excreted out through the process. So you have to have more of it in order for it to eventually hit the target and cause the desired response. So let's move on a little bit further to rate theory. And this, let's see, where did I really cover this? Okay, so at the beginning, I talked about how the response of the agonist is proportional to drug receptor combinations. More of the rate than the number. So even though you may have a large number, if it's not a big rate, it may not have that outcome. And this is talked about let's see. This is really talked about bottom of page 5, top of page 6. So you've got the response of the agonist. It's a result of a series of rapid association and dissociation of the drug and the receptor. So when you've got an agonist, it's like playing tag, but the agonist and the receptor are standing 1 foot apart. The receptor is not tagging back, but the agonist keeps on tagging every couple of seconds. The game doesn't end until the agonist gives up and goes away. So you have your agonist, and it's standing at the door and it's sticking the pick in, and then it pulls it back out. Then it sticks it in, then it pulls it back out. Then it sticks it in and pulls it back out. Okay? So it has a high, or not sort of high, but it has a rapid association and disassociation between the drug and the receptor when you're talking an agonist. Okay, so hopefully that makes sense with that. So it's connecting, disconnecting, 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 connecting, disconnecting. And that's why it has to do with rate rather than number. On page 9, it talks about inverse or reverse agonists. These have the opposite effect as full agonists. So you've got your full agonists, and they're talked about on page 6 because they're compared to partial agonists. So a full agonist means that you're getting toward 100% of the biological response at a very high dose. A partial agonist only produces a biological response, but it won't get the 100%. That would be a full agonist. So a partial only gets some. Then you get to this inverse agonist, and it does the opposite as a full agonist, but it's not the same as an antagonist, because we'll talk about antagonists again in a minute. But what an inverse agonist does is when it binds to the receptor, it essentially inactivates the situation. So it doesn't completely block the receptor like an antagonist. An antagonist blocks the receptor and either ends a response or prevents a response. An inverse agonist will bind to the receptor, but instead of turning the doorknob and opening the door, it just kind of sits there. It may turn the knob, but it probably won't open the door, or at least it won't open the door very far. So let's think about that. If you have a full agonist and it binds to a receptor, then it's going to turn the knob, open the door wide open, and that drug is going to move through and do what it needs to do. If you have a partial agonist, it's going to turn the doorknob, but it's only going to open the door part of the way. It will not, no matter how much of the agonist you try and push at it, it will never open the door all the way. That's a full agonist. Then you have these inverse agonists, and yeah, they turn the knob, but they're only cracking that door maybe by an inch. And they may turn the knob, but not really open the door. Whereas with an antagonist, it just blocks the knob. You can't turn it and you can't open the door. So the inverse agonist is not the same as an antagonist. So let's talk about that, because that's right here on this next slide. When you have a full agonist bind to the receptor, the effect is that you get the medication fully working. Okay, that's the nice red line here. A partial agonist they show by the orange. When it attaches to the receptor, its effect is that yes, there is a medication response, but it's not as big as the full agonist. Then you have an antagonist in the green here at the bottom. The antagonist says nothing's happening, and if something's happening, it's reversed. An inverse agonist is this purple. And when it binds, it essentially says, well, it's just not going to happen. Or if it happens, it'll be minimal. So it's exactly what it says. It's inverse. So they're opposites. A full agonist opens that door wide open and the medicine marches in. An inverse agonist opens the door, but the medication if it goes in, it's not gonna cause a reaction. It's gonna do the opposite. Whereas an antagonist just blocks the door entirely and nobody and nothing gets through, so nothing happens. There is no effect. So an inverse agonist essentially in some ways reverses the effect of a full agonist in some ways. And an antagonist will block an inverse agonist. That's also on page 9. So which of the following is the same as an antagonist? Quick quiz. Is a full agonist the same? Is a partial agonist the same? Is an inverse agonist? Are any of these the same as an antagonist? Hint, hint. The answer is D. Okay, so let's talk about agonists and antagonists. Agonists, again, are drugs that occupy receptors and activate them so that the medication can move forward and do what it needs to do. Antagonists are drugs that occupy receptors but do not activate them. They block receptor activation by the agonist. So let's look at our pictures here. On the left, you see you've got a circle agonist. It's in teal. And it goes in and it fits in that receptor. And the action is you have full reception. You have a big bang. That there's going to be, it activates that receptor so that the medication can cross and move forward. For every receptor, if you're taking an agonist and an antagonist, they're going to fight for every receptor. They're going to fight it out. And neither one may actually get the full receptor. If the teal agonist wins, then you have full activation. If the red T-shaped antagonist wins, as you see here on the right, there is no activation. There's just no response. And so that's why you can see that sometimes you have to increase the amount of agonist in order to increase your drug receptor combinations. But it's not so much the number as it is the rate. So keep that in mind. And we'll get into this in a little bit, but sometimes, even if you use more agonists, if you have the wrong kind of antagonist, it isn't going to work. But we'll get to that. So let's move on to receptor theory for antagonists. And this starts on bottom of page 7. We'll come back for efficacy and potency and therapeutic index, but let's talk about antagonists. These block or reverse the effect of all agonists or an endogenously produced compound like epinephrine or norepinephrine. Sorry, it's Monday. I'm having trouble getting this out. Beta blockers work like that. They're a compound that is produced by the body, and they block or reverse the effect of anything that's natural or man-made or drug-related, that type of thing. So an antagonist is a compound that binds to a receptor and produces no biological response. Remember, agonists bind and they produce a biological response, but antagonists, they just plain block it. They're like that stick in the doorknob. You can't get anything else in, and you can't get the doorknob to turn or the door to open. It's just slammed into place, and it stops anything else from happening. So let's look at this visual. The golden pin here is the antagonist. It binds to a cell's receptor and blocks access from all agonists, whether they are the gray natural ones or whether they're the red man-made picks. So an example of an antagonist that they give you is naloxone, which is also known as Narcan. And this is an opioid antagonist. It has no effect of its own, but it will completely reverse the effects of any opioid agonist that has been administered. That's how they work. They prevent anyone and anything, whether it's the body's own natural agonist or another agonist, from getting in there. So that's why antagonists are called blockers, because that's exactly what they do. Biological response of an antagonist is nothing, absolutely nothing. They simply keep all others away or reverse an agonist's hold on the drug receptors by commandeering as many drug receptors as possible. The biological response of an antagonist is the result of rapid association of the drug and the receptor with minimal disassociation. So it's like playing tag, but the antagonist grabs onto the receptor and won't let go. So the game is over. So remember, an agonist was like a game of tag, but you're standing a foot apart and you're one person's tagging the other person while they just stand there. So it's constant tag. And it isn't until the person who's tagging all the time decides to go away that ends. Whereas with an antagonist, instead of just tapping, they grab and hold on. And that receptor just stands there. And while that antagonist is grabbing onto it, there's nothing that, game is over because you can't do anything. So an antagonist has a high association rate but a low disassociation rate. Once they connect, that's why they're called blockers. Once they connect, they hang on and they block and they block and they block. Competitive versus non-competitive antagonists, and this is where it gets kind of sticky. Competitive antagonists block agonists from attaching to the same sites on the receptors, so it makes it look like the agonist is less potent at that dose. More agonist is required to beat out the antagonist to other receptors to get the desired response. So if you've got a competitive antagonist that's being given to a patient and you want to give them an agonist, you're going to have to use more of that agonist because you've got that competitive antagonist happening. If you have a non-competitive antagonist, this blocks agonists from attaching to the same sites on the receptors, and it reduces the maximal response that the agonist can produce. More agonist will not change the response because the antagonist irreversibly binds to the receptor, and sometimes it even changes the receptor shape itself. Meaning that if you're using a non-competitive antagonist and you want to introduce an agonist on it, it doesn't matter how much more agonist you give it, you're not going to beat that non-competitive antagonist. A visual for these. Let's look at this for competitive antagonists. You have an antagonist, that's this black piece here, and then you have the receptor, which is gray. So when you have a competitive antagonist, and then you have your little agonist here come along, it can't get in there because you've got the black antagonist there first. So the yellow can't get in. So the yellow needs to go find either another site on the receptor or it needs to go find another receptor. That's why if you increase the number of yellows you've got floating around, you can do it and get the response you want, right? Because this one's just blocking one side of the receptor and it hasn't changed the other areas around it that this yellow one could potentially attach to, this agonist could potentially attach to. Or the agonist could go off and find a totally different receptor and bind with it. So that's why competitive gives agonists a chance that if you increase the amount of agonist, you might very well be able to get the response you still want. Whereas a non-competitive agonist, watch this here, you have a spot on here that's yellow. And that's where your agonist is going to try and attach. But look, we have a red square non-competitive antagonist that's already there. And what happens when that antagonist is already there is, look down, you see how it's now changed the shape of that receptor site. So when the agonist goes and tries to hook in, it's the wrong shape now. It can't attach. So if you're taking a non-competitive antagonist and you want to use an agonist, it's not going to work. You can give the patient as much agonist as you want, but because the receptor piece itself that the agonist is going to try and fit into has now changed because of that non-competitive antagonist, you're out of luck. So, quick quiz. Which of the following statements about antagonists is false? Let's look at these. Antagonists can block or reverse the effects of all agonists. Is that true or false? Antagonists do not produce a biological response. True or false? Antagonists have a high association rate but a low dissociation rate. Is that true or false? All antagonists can be overcome or forced to stop their blocking action simply by increasing the amount of agonists. Is that true? Is that true of all antagonists? Hint, hint, hint. We just talked about that. All right, let's go back and talk about efficacy versus potency because they are different. And if you hear of somebody referring to them as the same thing, please understand they're confused. Efficacy is the maximal response a drug can produce. Potency is the minimal measure of the dose that's required to produce a response. So efficacy is how big of a response can this drug produce? Potency is how much of a little dose do I have to make any response? So that's how they're different. This is a visual, hopefully that'll help you see that. So you've got two drugs. You've got drug A and drug B. Drug A, look at the two lines. Drug A is blue, drug B is orange. There's a difference between the amount that they can achieve. Drug A can only go so far in terms of producing a biological response. Drug B can produce a much stronger, higher biological response. The difference between those two is efficacy. Now let's look at why. Why is the green line? And green is between A and B. That's potency. How much do you have to get a certain level of response? Now let's talk again about a partial agonist because we talked about full and we talked about partial. A full agonist is going to give you that huge full biological response. A partial agonist will never give you as much of a response as the full. It just can't. No matter how high the dose is that you give, that partial is never going to get there to the full. Both will exceed the minimum effective concentration, but partial will never ever get anywhere near the minimum toxic concentration. So let's go back to page 7 and talk about therapeutic index. Therapeutic index is a measure of drug safety. The higher the therapeutic index, the safer the drug is when you compare it to a drug that has a lower therapeutic index. Therapeutic index is calculated as being 50%, a lethal dose that kills 50% of test animals, divided by the drug's potency when it achieves 50% of the desired therapeutic effect. Therapeutic index is not the same as therapeutic window. So if you're hearing somebody try and refer to therapeutic index as therapeutic window, they're really not the same. But the index is a measure of safety, measure of drug safety, and it's at the 50% level. What is the lethal dose that kills 50% of the test animals divided by what is known as the effective dose that achieves at least 50% of the desired therapeutic effect? All right, so we just talked about that. Quick quiz. Which drug therapeutic index is the least safe? Well, here we said that the higher the therapeutic index, the safer the drug is. So let's look at these. You have arcane sulfate for epilepsy that's at a therapeutic index of 10. You have aprobarbital for insomnia at 5.3. Memantine for Alzheimer's at 3.2, phenobarbital for epilepsy at 2.6, and digoxin for heart failure and arrhythmia that is in the range of 1.5 to 2. So which drug is the least safe? Least safe. I'm hoping you pick digoxin because it has the lowest drug therapeutic index, therefore it's least safe. It's the one that has to be monitored the most closely and it has a very tight range of what you can give before it goes from therapeutic to toxic to lethal. Excuse me. Pardon me. All right, so let's move on to chapter 3, starting on page 11, where we're going to talk about absorption. Drugs are absorbed in different ways. Depends on which way you introduce it into the body, and we will talk about that with pharmacokinetics. And we did talk about it already. You could take it orally, it could be under the tongue, it could be IV, intramuscular, it can be subcutaneous, it can be topical, and suppository. So there's all these different ways. Most drugs, the vast majority of drugs, are given orally. They're either a liquid or a tablet or a capsule or something like that. They're orally administered drugs. When you take a drug, it's going to go into your GI tract, right? It's going to go in, you're going to swallow it, it's going to go down into your stomach. From your stomach, it goes into your small intestine. The blood from your GI tract, because you've got blood going on through there, and I'll show you some visuals of this in just a minute, is filtered by the liver. The liver. During liver metabolism, many drugs are reduced such that only part of the drug is passed back into circulation. Okay, and we'll talk about this again when we talk about chapter 5, but you need to know this is called first pass effect. When they're trying to figure out a dose of medication, orally administered medication to give to someone, they have to keep in mind first pass effect, where it goes through the GI tract, is filtered, it gets into the blood that's filtered by the liver. The liver then filters the drug, and only part of that drug is passed back into circulation to get to the tissues where it needs to work. So first pass effect is that you reduce the amount of drug that's going to be put into circulation because of what happens in the liver. So here's a visual for that. You have the drug, and it's coming in through the blood from the GI tract where it was absorbed, and this is called phase 1. It comes in through the liver does its work. It pulls out toxic intermediates. Whoops, sorry. And you've got the active drug there. Then as it metabolizes, you get to an inactive drug. And that is what goes back into the blood. So you have the drug, it comes in, it's active, it's metabolized, it's inactivated in some ways. It's not nearly as strong or powerful as it was when it came through the liver because it's been metabolized, and then it's sent off. And anything that's an inactive excretion product ends up in the urine or the bile. What are some factors that affect absorption? It can be related to the drug itself. Is it lipid or water soluble? What is the molecule size? What is the particle size? What is the degree of ionization, physical forms, chemical nature, dosage forms, formulation, concentration? Then let's talk about factors that affect absorption that are related to the body. There's area of absorptive surface, vascularity, which has to do with the blood flow, pH, presence of other substances, GI motility, your GI tract and how quickly it moves through its processes, functional integrity of absorption surfaces, and diseases. Which organ is most involved in the first pass effect? We talked about that. Which organ is the most involved in the first pass effect? Which organ does the metabolism, the actual metabolism, where it changes the drug and decreases the amount of it that leaves this organ? All right, so let's talk about distribution. How do the drugs then cross membranes? So you've got it in the body, and it's gone through liver metabolism, and now it's back in the blood, and it's headed to the tissues where it needs to do its work. How does it then cross the cell membrane? If you're looking at your book, this is bottom of page 11. There are three things that impact this drug crossing membrane process. The first one is the type of transport that needs to happen. Is this diffusion passive transport, or is this active transport? And we'll talk about the difference between those two. Is the drug molecule charged or uncharged? Is it positive or negative? How is that going to impact it trying to cross the membrane? Is it acidic or base? And how does that impact its process of crossing membranes? And then we're going to talk about bioavailability. This is the amount of a drug that's absorbed after administration by any route except IV, compared with the amount of drug that is absorbed after IV. They do this to be able to see how much drug is lost by any other route other than IV, because when you inject an IV, it doesn't go through the liver. It's not, oh, how do I explain that? The drug is inactivated by different things. The example they give here in this book is they say, in the case of hypothetical new drug, you discover that some of the drug is inactivated by the acid in the stomach. So you need to redesign the pill with a coating that is stable in acid, but dissolves in the more basic pH of the small intestine. So the bioavailability of the drug will increase. So that's why you do it. You do it to test to see, because IV administration theoretically is 100%, and administration by whatever other route, that you can see where you lose some of the drug to try and go back and reformat it. So let's go back. Let's talk about drugs crossing membranes and the different things that impact that. Diffusion passive transport means that it crosses the membrane without any effort. It just slips right through. It diffuses. It just slips right through passively. There's nothing that has to take place, nothing to force it through, nothing to pull it through. It just happens all by itself. While no one's paying attention, it just diffuses through. It's passive transport. It happens. Active transport, on the other hand, requires ATP, which is another word for energy. And so you have to have the body releasing energy, or meaning the cell. The cell itself has to release energy in order to move these molecules past the membrane and into the cell. So let's say you have a drug and it's gotten all the way to the cells of the brain. If this drug crosses the brain cells membranes through passive transport, diffusion, passive transport, it just happens. If, however, it needs active transport, then the brain cells are going to have to release energy that they've got in the cell in order to get those drug molecules across that membrane. So that's the only difference, is that active transport requires the cell to release energy in order for it to cross the membrane. Now let's talk about charge. There are charges to things. Did you know some things are charged positively, some things are charged negatively? You notice down here under ions, you've got K+, that's potassium. It's a positive charge. Then you've got Mg2+, Ca2+, Ca2+, that's calcium. Again, you've got that plus. It is a positively charged ion. Cl- chlorine or chloride, that is negative. That has a negative charge to it. And then you see HCO3, HPO4, 2-, and you've got all of those, and those are negative. So let's take a look at that. When you've got these ions and they are specifically charged, they are impermeable to a membrane. They have to be broken down into something else that is permeable. So for instance, gases, just the way that they're built, they are permeable. They'll go right through a membrane, no problem. Small uncharged polar molecules like ethanol and water and urea, those can be permeable and slide right through. Large uncharged polar molecules like glucose and fructose, those are impermeable. And you go down here, and then ions were impermeable. Charged polar molecules, those are all impermeable. So something has to happen on a charged basis in order for them to move across that membrane. So that's why you need to know, is something charged or not charged? Now, after this week, you are not going to have to worry about charged. You're not going to have to worry about active or passive transport. You're not going to have to worry about, is it acid or base? I'm only giving it to you here because it has to do with absorption, distribution, and clearance. Otherwise, we wouldn't even be talking about it. So as we go forward, you won't have to know any of this. You don't need to know this for the test, but you need to know that whether or not a molecule is charged, whether or not it's acid or base, and how it goes across the membrane by either active or passive transport, those all are implicated in how a medication can cross a cell membrane. That's all you need to know, not the details. So let's talk about acids and bases. Why do you need to know whether something is an acid or a base and how strong it is? Well, you need to know that some things can be absorbed along the entire length of the GI tract. Like very weak acids, those can be absorbed anywhere, the entire length of your GI tract. But moderately weak acids are better absorbed from the stomach. Strong acids, they're poorly absorbed from the GI tract, so you might need to figure out a different route other than the GI tract when you're talking strong acids. Very weak bases, they're fine. They can be absorbed anywhere along the entire GI tract. But moderately weak bases, now they need to be absorbed from the intestine, not from the stomach. And then you have strong bases, again, poorly absorbed from the GI tract. So if it's a strong base or a strong acid, you need to know that when it's a drug, when you're designing a drug, if you're trying to get it to be absorbed from the GI tract or somewhere along the way. So this is an example of why you would want to know, is it acidic or basic? But again, unless you're designing drugs or unless you're prescribing drugs, you probably don't need to know that. So back to bioavailability. On this visual, this is a really good example. What they're trying to do is to see how much of the drug actually gets to the patient if it's provided a different way than IV. Because when you provide something IV, it goes straight to the heart and then from the heart to the target site. That's why a lot of critical drugs that need to be done quickly, where you need to have a very quick reaction, you do by IV. Because you need to get it right to that target site as quickly as possible. Whereas, whereas if you have a drug and you give it PO, it comes down, it goes through the stomach, it passes through the stomach into the small intestine. In the small intestine, it's absorbed by the the blood of that intestine is pulled out through there and sent to the liver. It has first pass effect, then it goes to the heart, then it's sent to the target site. And some of it ends up being eliminated. Whereas the IV goes straight to the heart and straight to the target site with no elimination in there. Did you notice that? So why do they do bioavailability? Because you want to see what is the percentage of the drug that's going to reach the systemic circulation unchanged, and look at what are the losses you're going to see due to poor drug absorption via the gut and the first pass effect, which is liver clearance or liver metabolism. It's just a way to help you see how much is being pulled out before it ever reaches the target site, so that you can keep that in mind when you're looking at oral dosing versus IV dosing. Again, are you ever going to need this kind of detail after this week? Absolutely not. And even I won't ask you that kind of detail. I'm really looking that you understand that bioavailability is comparing the amount of drug that's given IV and goes directly to the target site versus the amount that's going to go through and a different route, and how much is going to be weeded out before it ever gets to the target site, to compare how much you're going to lose. All right, so let's move on to clearance. We've talked about absorption. We've talked about distribution to some extent. Now let's talk about clearance. Clearance means the rate at which the drug is cleared from the body. It's defined as the volume of plasma from which all drug is removed within a given time. Your total body clearance is the sum of all clearances from various organs involved in drug metabolism and elimination. So when they're talking about clearance, that's the rate at which the drug is removed from the body. So let's take a look at this. Again, you don't need to know these formulas. You do not. My point in showing you this is that clearance is measured in volume over time. How much of that plasma, how long is it going to take for us to get a volume of plasma that doesn't have the drug in it after you give the drug? And then you're looking at your rates of elimination, and that's going to include what comes out of the renal system, which is your kidneys, your hepatic system, which is your liver, that first pass effect, and then it may also involve lungs, depending on if that is an area that is involved in the whole process. Okay, so all I really want you to know about clearance is just what the book says. It's a term that indicates the rate at which a drug is cleared from the body, defined as the volume of plasma from which all drug is removed within a given time. That's all you need to know. And total body is probably going to be kidneys, liver, and lungs. You add those clearances together to get total body clearance. All right, let's talk about chapter 4, which is kinetics, pharmacokinetics. This starts on page 16. And I apologize for how long this video is. Hopefully you've paused it along the way and gotten up and taken a few stretch breaks. But this is just so foundational. There's a lot here. I get that. But it will help us to understand if we take all this information to heart. It's just really good background. And again, after this week, we won't get into this kind of weedy detail in terms of getting down to it, because that's, you need to understand the background, in my opinion, in order to then just talk about drugs and effects. If you don't understand what absorption is, then when we start talking about the drugs, it won't make any sense. And same thing with distribution, metabolism, and excretion. So speaking of that, pharmacokinetics. This is absorption, distribution, metabolism, excretion. You've got to know those 4. So pharmacokinetics equals absorption, distribution, metabolism, and excretion. And it's rate and extent of those. But I need you to memorize pharmacokinetics equals absorption, distribution, metabolism, and excretion. I need you to have those 5 words together. Absorption is how does the drug get into the body? Distribution is where will it go once it's inside the body? Metabolism is how is it broken down inside the body? And excretion is how will it leave? So here's a visual for you. Absorption, how is that medicine getting in? Distribution, where will it go? How is it transported? Metabolism, how's it broken down? And then excretion, how does it leave? Does it leave through the digestive tract? Does it leave through the kidneys? Does it leave through bile? There's all those types of ways. So A, D, M, E are the letters. If you want to memorize the letters, A, D, M, E. Absorption, distribution, metabolism, excretion. Make sure you know that. Hint, 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 hint. And there we go. Which mnemonic can help you remember the description of the steps involved in pharmacokinetics? I know you can get this one. All right, so moving on to kinetics, we're going to talk about first order versus zero order. And this is on pages 17, 18, 19-ish. Excuse me. All right, first order. A constant percentage of the drug is lost per unit time. These drugs have a constant half-life, and we'll talk about half-life. First order drugs, a constant percentage is lost. Zero order means a constant amount is lost. So in an hour, a constant percentage of the drug is lost. That's a first order kinetic reaction. If you're looking at an hour and you see a constant amount of the drug is lost, that's zero order. So it depends on how you're looking at it. Half-life is constant for first order kinetics. And thankfully, most drugs, I guess before I start, I really should back up. Most drugs are first order kinetics. That's how they disappear from the plasma. So first order is how most disappear from plasma. It's a constant percentage of the drug over time with a constant half-life. There are some drugs that are called zero order. That's how they leave the plasma. It's a constant amount of the drug is lost, and there is not a constant half-life. It depends on the drug concentration. Half-lives vary from person to person and can vary based on a number of factors. So let's talk about half-life. Half-life is the period of time required for the concentration of the drug to decrease by 1/2. Okay? So first order drugs, they disappear from the plasma at a constant percentage over time. So that's why their half-life is constant, because it's a percentage over time. So you can calculate the half-life, it's consistent, it's constant. It's not going to change. Zero order drugs disappear from the plasma by losing a constant amount of the drug over time. And because it's an amount of the drug and not a percentage or a concentration, the half-life is not constant. You can't guarantee that it's going to be the same amount of time, the specific period of time. I hope I haven't just really confused everybody. All right, so half-life. This is the time it takes for the concentration of a drug in your body to be reduced by half. Traces of drug use can be found in urine, blood, saliva, and hair. Different illicit drugs require different tests. And one example I was able to pull up was cocaine. In most cases, the effects of cocaine last 20 to 30 minutes, but the half-life of cocaine can be detected via urinalysis 2 to 4 days after the last use. Okay? So even though the effects fade in a short period of time, the concentration of that drug, cocaine, in your system is a first order kinetic, so the half-life is constant and can usually be detected 2 to 4 days after the last use. All right, so here are some half-life examples. And one of the things to remember is if you have a short half-life, the drug's going to wear off quickly. Because in order to keep, if the half-life is short, you have to keep the concentration in your body steady. You have to take the drug at least every half-life to keep your concentration steady. Whereas with drugs with long half-lives, they don't wear off quickly. They wear off after a long period of time, and they can build up in the body, and you can end up with really high concentrations, even if you're only taking them once a day. So the example they give us here is that Prozac is a long half-life drug. It's still first-order kinetics because we can still predict that its half-life is constant, but its half-life is so long that it can still be in your system 6 weeks after you take the last dose. So they give you some examples here of Ativan, Coumadin, morphine, amiodarone. And you can see the differences in the half-life. Okay, so let's take Ativan. It has a short half-life of 2 to 3 hours. So you have to take it, on a regular basis to keep it up. But once you stop taking it, it's out of your system very quickly. So you never really can get to too high of a dose because it has such a short half-life. But it requires more frequent dosing. Coumadin is a blood thinner. It has a long half-life, not a very long, but a long half-life. I want to say it's a few days, 3-4 days maybe, depending on how much you've got in your system. The good thing with the long half-life is that it continues to prevent clotting even after you stop taking it, at least for those couple of days. The bad part of it is that you can still bleed and have the side effect of the bleeding because the Coumadin is still in your system even after you stop taking it. And if you take too much Coumadin, with that long half-life, it builds up, and you can have internal bleeding because of the Coumadin. Morphine, again, is a short half-life drug. Most opioids are. And so you have to watch out how frequently you need to dose because it's constantly getting decreased in terms of concentration in the system. So that's why you see cancer patients who are sometimes on a morphine pump so that as their pain comes back, they can simply click on it and it gives them another dose. And that's because it has such a short half-life. And then it gives you an example of amiodarone, which has a very long half-life of 100 days. So it takes a long time to build up to the concentration you need in your system, but you're going to have side effects. And even after you stop taking it, it's going to stay with you for 100 days. And you have to watch that you don't get too much, too high of a concentration in your system where you do have those side effects. Hopefully that makes sense about half-life. So let's do a quick quiz. Which of the following statements regarding half-life is false? Half-life is the amount of time it takes for the concentration of a drug in your system to be reduced by half. Yes. Half-life is always constant. It never varies. Is that true of both first-order kinetics and zero-order kinetics? Hint, hint, hint. Drugs with long half-lives will wear off slowly. Yes, that is true. Drugs with long half-lives can build up in the body and reach high concentrations even if you only take them once a day. That is unfortunately also true. All right, steady state concentration. Moving on to page 20. With multiple dosing or continuous infusion, a drug will accumulate until the amount administered per unit time is equal to the amount eliminated per unit time. Do you see what that is? You get that, you start giving a drug and you keep giving it until the amount of drug accumulates in someone so that what you're giving them in a period of time is equal to the amount that they're eliminating in that same period of time. When this happens, the plasma concentration rate is called steady state. And this is the average concentration for optimal response by the drug for the patient. You do repeated dosing, And in your page, in your book on page 21, it shows you this under figure 4.6. You're going to have peaks and troughs because as you give it, it's going to slowly wear off. Then you're going to give another dose and it's going to go up. Then it's going to go down. But it's within a certain range. That peak and trough plasma concentration is within a specific range. That is the average concentration needed to maintain that steady state. The time needed to reach steady state depends only on the half-life of the drug. That's why you got to know the half-life, is because it'll help you know if the half-life is 2 to 3 hours, you can reach steady state in 2 to 3 hours. Whereas if the half-life of the drug is 100 days, it's going to take 100 days to get to that steady state or that optimal result or optimal response of that drug. Thankfully, 90% of drugs are usually reached in 3.3 half-lives. And now we're only talking about first-order kinetics where half-life is constant. If we're talking zero-order kinetics, that's not true. But 90% of drugs usually reach steady state concentration in 3.3 half-lives if they're a first-order kinetic drug where the half-life is constant. Hopefully that makes sense. Loading dose. Sometimes they give a large single dose of a drug used to raise the plasma concentration to a therapeutic level more quickly than would occur through repeated smaller doses. Has anybody ever taken a Z-Pak or ever taken a pack of steroids? They typically have a leading dose. You might take 2 or 3 tablets instead of 1 daily tablet. That's because they're trying to bump up your plasma concentration to a therapeutic level more quickly. That means that they're trying to give you more than the half-life to get you up there. It still has to be followed by repeated doses or a continuous infusion to maintain the plasma concentration at the desired level, but it's a way of skipping steps and getting you there quickly. And it's usually used when the half-life of a drug is relatively long and waiting for the drug to reach steady state or a therapeutic level would negate any benefit to the patient. All right, moving on to chapter 5. We are on the home stretch. Hang on with me. Drug metabolism and renal elimination. Let's talk about liver metabolism again. The drug, if it's given orally, it comes through, hits the stomach. In the stomach, it is absorbed in the small intestine typically. And from the small intestine, the blood circulates over through the liver. In the small intestine, some of it stays, not necessarily the drug, but there's other ingredients in a drug that are just used to get it to where it needs to go, not part of it. And those are waste products that end up going through your large intestine and out through your feces. But the drug itself, the active drug that is necessary, goes through your liver. It's metabolized. The bioactive drug itself is sent out through the blood for systemic circulation to get to those cells. The drug metabolites are sent to the kidney. They're processed in the kidney and excreted through the urine. So make sure that you know that process. Renal excretion. This is on page 25 in your book. There are 3 physiological processes in renal elimination. The first one is glomerular, got to get that out of my mouth, glomerular filtration. This takes place here in the Bowman's capsule. The free drug is filtered, and the amount that's filtered is determined by the renal blood flow, the glomerular filtration rate, and any plasma protein binding. You don't need to know that level of detail. What you do need to know is that is glomerular filtration. That is the first step of renal elimination. You also need to know that the size of the molecule is the only limiting factor. So if the molecule is too itty bitty, it's not going to get caught in this process. Okay? The second step is proximal tubular secretion. This takes place the second it's the second step. It's after the Bowman's capsule. It's here, and it is where you can see up here there are these molecules and they're flowing through. So you've got, let me start down here at the bottom. You've got your drug molecule, and that's this little purple thing here, and it's coming through. It's going to go through the glomerulus, which is part of the Bowman's capsule here, and it's going to be filtered. And as long as it's not too itty bitty, it will be filtered out at this point and go into the yellow, which is the renal tubule, which is part of where it will end up being excreted as urine at the very end. So as long as it's not too itty bitty, it will be filtered out, and that will be the end of it. If it is too itty bitty, it continues through this process around, and then it gets here in the proximal tubular section, and it's secreted out. Okay? This is especially important if it's a highly protein-bound drug. It's secreted at this point into the renal tubule. So if it's a big molecule, it's going to get pulled out through the filtration process. After the filtration process, if it's still in here, it gets bounced around, it comes around, and it's going to get secreted across into the renal tubule, especially if it's a highly protein-bound drug. All right, now let's say for whatever reason, somehow it doesn't get secreted. Maybe it's not a highly protein-bound drug. It's itty-bitty, but it's not highly protein-bound, so it misses the secretion step. It's already skipped through filtration. It's already skipped through secretion. What happens next? Well, it comes down, and it's now into the distal tubular section, and it's going to get reabsorbed. And this is where lipophilic, which means these are the fat-soluble drugs, get pulled out. They get reabsorbed, and they end up trapped in the urine. And so they can't get reabsorbed back out into, they can't stay where they're at. They get pulled through reabsorption into the urine. Okay? And this is where it talks about charge. It says uncharged drugs may diffuse out of the kidney and escape elimination. Manipulating the pH of the urine may alter this process by changing the ionization of weak acids and bases. This process was described in Chapter 3 in the context of passive diffusion of drugs across membranes. However, for a drug to be excreted, meaning into the urine, it needs to be charged so that it's trapped in the urine and can't cross the membrane to sneak back into the body. So what do you need to know? You need to know the three processes. Number 1, filtration. Number 2, secretion. Number 3, reabsorption. You need to know that in filtration, if it's too itty-bitty, it's going to miss filtration, and you hope it's caught in secretion. Secretion tries to catch anything that's highly protein-bound and put it back into the urine. And then it can go further. And it can be reabsorbed. If it doesn't stay in the urine, it can get reabsorbed at this point and go back to the body, and that's why charge matters. And that's why urine pH matters. And along with all of this, you can see why patients who have renal problems and their kidneys are not functioning well and they might be on dialysis, can you imagine how much harder this process is? And how much more drug remains in their system because it can't be filtered out, or it can't be secreted back into the urine, or it constantly gets reabsorbed, or it doesn't get reabsorbed. All of these things, patients with renal issues, this whole renal excretion process is disrupted and sometimes brought to a screeching halt, and that's where you get into dialysis. So that's why we need to understand all of these. Okay, pathophysiology. I'm going to tell you that pretty much we will not use pathophysiology, and if we do, we will just use the GIST boxes. And even there, it will be limited to what is applicable to us. And today, what is applicable to us is the first three items, the first three boxes. Pathology is a study of structural and functional changes in disease. Pathologic changes present with clinical features known as signs and symptoms in the patient. In pathology, we study causes, which is also known as etiology, mechanisms, pathogenesis, how did this happen, and arrive at final diagnosis by various lab methods. Gross and microscopic examination of tissues is the major method. The rest of that, you don't need to know. And none of the information in pathophysiology will be on your quizzes, unless I specifically tell you so. So again, the only thing you need to know from the pathophysiology book will be in the GIST boxes, and it will be the things that I point out to you. And if it will be on the quiz, I will tell you, but I can tell you for week 3, there will be nothing from pathophysiology on the quiz. Okay, cells, looking at cells in chapter 2, the GIST box, the things I'd like you to know here are that initially, number 3, initially cells adapt to the changes due to injurious agents and may revert back to normal. Box number 4, mild to moderate stress for shorter duration causes reversible cell injury. Severe and persistent stress causes cell death. Okay. Also, number 2, the cellular response to stress depends on the type of cell and tissue involved and the extent and type of cell injury. So it all varies. It all varies, and that's what we need to know about cells. And you think about how cells are involved with how medication is metabolized and activated. Cell injury then suddenly becomes serious, doesn't it? So these are our review questions. There's 4 slides of them. Make sure you know the answers to these based on the lecture video and also your book, but most of it's the lecture video. What is an agonist and how does it work? What are the unique kinds of, what are the different kinds of agonists and how is each one unique in its activity? What is an antagonist and how does it work? What are the different, spelling error there, different kinds of antagonists and how is each one unique in its activity? What is efficacy? What is potency? How are they different? What is therapeutic index? Why do you need to understand the difference between high therapeutic index drugs versus low therapeutic index drugs? What is first pass effect and where does it happen? What is the difference between diffusion, passive transport, and active transport? Why do you need to know about charged versus uncharged molecules? Why do you need to know about acids and bases? What is bioavailability? How is it measured? And why is it measured? What is clearance? How is it measured? Why is it measured? What is pharmacokinetics? What are the 4 steps or stages? What is a first-order drug? What is a zero-order drug? How does this classification affect their half-life calculations? What is half-life? And why do you need to know a drug's half-life? What is steady state concentration? When is the state reached in terms of drug concentration? How does half-life play into steady state concentration? What is a loading dose? Why and when is a loading dose used? What happens during liver metabolism? What is renal excretion? What are the 3 steps involved in this process? And there are no questions on pathophysiology or cells on this week's quiz. There are 20 questions on this week's quiz, and I know that you will ace them if you know this information. All right, take care, have a fabulous week, and I will talk to you again soon. Bye.